So here we have Ashley. Ashley is one of our dental assistants that's been complaining of TMJ pain. We haven't, or I haven't necessarily done an exam yet, but I wanted to use this opportunity to look at the joints, or a joint, on the cone beam CAT scan. This particular screenshot doesn't include the TMJ slice, but if you look at the top of the in vivo software, you will see the TMJ tool. You click on that and you get this view here. Typically what I'll do is I will take this orange line in the upper left corner and I will superimpose it on the condyles. You may not see the condyle in this view, but what I try to do is I go up and down and I'm looking at the area of the condyle in this coronal view. My goal is to get a cross-section of the condyle so that I can then come over here and place this rectangle right over the condyle, which then gives me these sagittal views. Oftentimes the software actually puts you back here, so it's kind of difficult to look at this image here and get a sense. But what I will do is I'll come over here regardless of the image I have here, and I'll take the orange and go up and down, and I'm looking for the condyle in the coronal view. Once I get the largest cross section of the condyle, I'll then take this rectangle, put it right over the top of the condyle, do the same on both sides. All of these green lines are these 6 images here. So there's 6 slices that give you a cross-sectional view or an orthogonal view from here to here. These 2 images are 90 degrees from each other. As with all CAT scans, or at least any CAT scan that I've seen, a tool or a trick I use is the following. There are typically 3 colors to the lines that you will see in the image. And each image is a 2-dimensional representation of reality, and there's typically 2 lines. In this entire screen here, I can see an orange line, I can see a light brown line, and a green line. Ignore this yellow line right here, and then obviously the rectangular box. But these lines here, you will see in the arch view, in the sectional view, and also the piano view. So the point I'm trying to make is this image is represented in the other images on the color that's not in this image. What do I mean? Well, there's no green line here, so if I look at the green line in other images, this green line corresponds to this view. It's always a 90-degree angle from the 2-dimensional view that is represented here. So if you were to take this slice and look at it from the left or the right, this is the image that you would see. Likewise, we do not see in this image here, well, the TMJ view is a little bit different, but I think you get the point that you're always looking for the color that's not in the image you're looking at. You're looking for the color of the line in the other images that you see. The image itself is the color of the line that's not in the image in the other views. Super hard to describe, but I think you get the point. So that's just a quick rundown on how to look at the TMJ views. If you want to change these views here, you can take the green lines and do like so. So you're getting a sense of what the entire joint looks like. You can also take this brown line, again, brown, I don't see any brown up here. This image here corresponds to this line right here. If I want to see the cross-sectional view in the middle of the condyle in this image here, I will take this brown line. Again, there's no brown line here. that means this image is the brown line here, and I'm going to slide it forward. As you can see, I'm now in the middle of the condyle. That makes sense. I can now see the condyle slice as taken right here. Okay. Let's do a little bit of anatomy. Nasal passages here. Here's the maxillary, the frontal sinus. Let's see. Yeah, maxillary sinus. I believe that would be your ethmoid, maybe. Never really looked at the sinuses from this view. Typically I'm looking at the arch section. Guess I'm going to have to revisit that, but essentially getting a sense of where you are in three-dimensional space is always important. Okay. I was looking at a few different things here. Obviously, right here you have the brain. So the TMJ complex lives very close to the cranium. The cranial base is actually the superior compartment of the TMJ. Obviously, the ear canal we can typically see posterior to the TMJ compartment. You have the retrodiscal tissue, the condyle. It's sometimes visible, but the disc is sometimes hard to see. This is actually a fairly pathologic joint, which we'll take a look at in a moment. Let's come over to the left joint, which I think is in better shape. That looks like the disc right there. Again, I haven't looked at the patient. I have no idea. My guess is if I was to palpate her right joint, having her open and then palpate right in front of the tragus, she would have quite a bit of inflammation inside this joint. She'd most likely represent some discomfort there. Very possible there's some myofascial pain disorder concurrent with the intracapsular issues, which we tend to see. So a full exam is definitely warranted. I just wanted to walk through this to get a sense of what to look at on the CAT scan. Again, that's probably the disc there. We don't use CAT scans to assess soft tissues. With that said, sometimes you can get some idea of where the where the disc is. My guess is this disc is properly placed. She may have anterior disc displacement with reduction. It really depends on whether or not you hear clicking or popping, but I would say that this particular disc looks well positioned. If you look over here, the condyle is very close to the base of the skull. If we kind of scroll back and forth, I can see as we get to the medial pole, and in the SPEAR TMJ continuum, they talk a lot about the medial versus the lateral pole. It's not something I'm going to talk about here, but it is something that has significance. We tend to think of the condyle as this image here, when in reality, the condyle is obliquely positioned in relation to the glenoid fossa in which the condyle lives in. Therefore, when you have clicking and popping, it's not the disc necessarily popping completely off the condyle. Sometimes it's only the medial pole, sometimes it's only the lateral pole, and sometimes it's the entire disc. Just keep in mind that when you get really good at TMD diagnostics, you'll start to tease out whether it's the lateral pole or the medial pole, and then treat accordingly. So it gets fairly complex. Topic for another day. What I was looking at was the relation of the condyle to the glenoid fossa as I was scrolling back and forth here. As you can see, right around the beginning of the lateral pole, you can start to see what looks like the condyle living right up against the glenoid fossa. It's tough to say whether this is the fossa. Maybe that's the lateral pterygoid. The lateral pterygoid inserts at the superior head of the condyle. It also inserts onto the disc. Remember, the lateral pterygoid has an inferior and a superior belly. So it's very possible that's actually just the muscle itself. The point is, this looks messy. It's hard to delineate what's going on, as opposed to the left side. I can see the cortical border of the condyle. I would say the cortical border is actually somewhat discontinuous, which might mean there's inflammation in the joint. But over here it's harder to see. In addition, we have these radiolucencies. These are called subchondral cysts. Subchondral, sub meaning under, chondral meaning the joint, or the chondral referring to the tissue of the joint. So subchondral cyst, obviously a cyst is a empty space. This is also called osteoarthritis. There's many different terms to describe this condition. In a nutshell, there's inflammation in the joint space. That inflammation is causing the bone to change. Another term, osteophytic changes. So there's different ways to describe this. The point is, I have no doubt there's inflammation in her right joint. In addition, when I look at this view here, it looks like the condyle is fairly close to the superior border of the joint space, or the superior border of the joint. So the space is very minimal here. As you can see on the medial pole, it looks like it's actually touching. Now there might be a little bit of movement when this image was taken. It's hard to say whether this radiolucent area is an artifact of movement, or if this is actually a radiolucency. I don't think I've ever seen it this clean looking, so I might say that it was movement. But you get a sense of what we're trying to look for inside the joint. There's just a general loss of cortication on the condylar head. This is not uncommon in a patient that suffers from TMD, intracapsular TMD. Obviously, if there's a muscle problem and there's no issue with the joint, you wouldn't see this. But anytime you see intracapsular issues, that would be likely to show up. As we go to the medial pole, the space starts to look better. So it's not uncommon when we see the lateral pole get involved with the lateral component of the superior compartment of the TMJ space, that we have what's called capsulitis. There's a capsule that holds the joint in place when you slide your jaw left and right. What really holds the condyle in place from being displaced laterally is a ligamentous attachment, and if that ligamentous attachment gets inflamed, it's called capsulitis. You can palpate that area very easily. You have the patient not do anything. You just palpate that area, and if the patient has discomfort, that's suggestive of the diagnosis there. But again, the purpose of this wasn't necessarily to run through diagnosis. It's more a tour of the TMJ joint, what to look for. You're looking for these osteophytic changes. You use this radiographic analysis in conjunction with a clinical exam to come up with a diagnosis or a set of diagnoses. So, next step for this will be to do a full head and neck exam. We're not just looking at the joint, we're trying to get a sense of the airway. Airway is often the reason why we see issues with the TMJ. But we'll dive into that more later. In a nutshell, I think this particular patient needs to be relieved, so we're going to take her condyle, bring it down and forward. That's really the first line of defense for most TMD cases. So we'll see you at the treatment side of this.